everyone and welcome to Rad Chat. So welcome to podcast number 25. My name's Jo McNamara and I'm joined by my fellow host, Naaman Jolka Anderson.
Hello.
A big thank you to our last guest, Professor Heidi Prost, who discussed her career, research and why the patient's voice is so important. If you haven't had a chance yet, please do go on, take a listen. It's a really great one. So we are really pleased to introduce our guest for this evening, Ben Potts. Ben's going to be discussing neurodiversity within radiography. So welcome, Ben.
Hi, pleasure to be here. Thanks so much for asking me. You know, I'm a big fan of the podcast, so I'm honoured.
No, that's lovely. I do. It is great when you start to have some real actual followers that constantly tweet and engage with social media. It's really nice and it's reassuring for us as well. So thank you so much, Ben. And it's an absolute pleasure to have you on. So I know Naaman and I know you, but would you like to introduce yourself for the audience and talk a little bit about kind of what you're doing at the moment, what your career pathway's been to date?
Yeah. So I think my pathway into radiography might be the strangest one, or at least the most convoluted. So I started. So I'm a mature student. I'm 31. I started my studies when I was 20 in music technology. So not related to radiography at all. And then that progressed into kind of somewhere between music and contemporary art. And so I did that. I studied that, and then I had a period of illness, mental health issues, depression, anxiety, and I was quite ill for a while. And during that time, I was also caring for my grandmother as well. And I just had this desire to want to get into healthcare. I think something had been there from when I was young, but it was very clear at the time. And I was looking down the list of healthcare professions, and I didn't really want to do nursing. Decided that straight away, and then I looked down the AHP list, and radiography just stuck out to me because I've had some chest X-rays before, and it just seemed like a really good mix of the technology side that I'd done before with music tech, and then obviously I wanted to get into patient care and that side of stuff. So it was really good, stuck out to me straight away. And yeah, now I'm a second year radiography student, diagnostic radiography at Birmingham City. I'm the vice chair of the Society of Radiography Student Representative Forum, and I also do a bit of work with Health Education England on their AHP placement advisory board, which is looking to expand capacity in placements.
Amazing. So Ben, you've already achieved so much and you're literally been in the profession 2 years, so that's amazing. It was really interesting actually that you commented on using the prospectus and kind of looking down. It is still something that people actively do to look for careers, and it is so important, isn't it, that the information that's presented there is almost enticing. I always think, you know, when people go, oh, you know, there's lots of projects we could do to promote different professions or AHPs. I'd always say, yes, absolutely amazing. You can't kind of relax and just expect people to come into the profession. But I am also really aware of how much people use prospectuses, and maybe online prospectus and UCAS. And did you look specifically at a university? Did you know you wanted to study close to home?
Not particularly, no. I was looking just at the professions and what's involved, you know, how what skills do you need, and really I was thinking about how much patient care is involved as well, because I knew I wanted to do that, but I didn't want to go kind of too much into it like nursing. So yeah, that's why I was looking for like a Goldilocks profession where it was just right for me. And then yeah, once I kind of decided radiography and I wanted to do diagnostic, it was then like looking, well, where do they do it near me? You know, and I was really lucky that Birmingham City do it, which is very close to me. So
I was going to say you are very lucky.
yeah.
So Ben, I know everyone is going to expect me to ask this question, but why didn't you choose therapeutic?
Oh, I don't know, to be honest. I think what initially put me off, I think, was probably the difficulty of it, like with seeing patients that were going through some very hard times. I mean, obviously
Yeah.
you get that in diagnostic as well, but perhaps to a lesser extent, because you also get children that have said that they've hurt their finger at school so they can get a day off, which they probably haven't hurt the finger at all. So you get some lighter stuff as well. I think that was the deciding factor for me.
So Ben, a little birdie told me that you've actually got a PhD already. So what kind of study have you done previously to doing this?
Yeah, I started off with a bachelor's of music technology, and that was I started off playing drums. That was my entrance into music tech. Started learning drums from a child from like age 10, and as I got into uni, into the course, I got more and more into the electronic side and production and programming and all that side of music tech, and I ended up getting a scholarship then to study computer music, which is like electronic music but a bit more arty. That was a PhD, and my PhD was kind of a mix between contemporary art and electronic music, and also a bit of audiology thrown in as well. So it's really a lot of RT PhDs are very hard to explain exactly what they're about. I think with like science ones, you have like a distinct research question that you're looking at, whereas art ones can be a bit more rambly.
So Ben, do you go into clinical and go, I'm Dr. Ben Potts?
No, I have had people ask me, because when they see a mature student in departments, they want to ask straight away, what did you do before? What are you doing here? Yeah. And so people have asked me, and I've said like, oh, I've done a PhD, and then people are kind of like, well, what are you doing here? Like you've almost like you've already cracked it. You've done a PhD in music. Like what you've won life. Why are you doing in NHS? People do ask me, but I don't really use the title really now because it doesn't really having to do with what I'm doing at the moment. But I only use it for like Amazon deliveries and that sort of thing.
I'm Admiral on our Amazon. So yeah, you can get all sorts on there, can't you? You can select, but yeah, entertaining.
Yeah, it's interesting you said about the difference between diagnostic and therapeutic, Ben. So obviously, as you said, for us it can be a bit heavier, but I suppose with your experience of working in A&E and stuff, you do still get some of that heavy element, I suppose, but in more of a multidisciplinary way, don't you?
Yeah. I mean, it's I shouldn't really make light of it because there is some very serious stuff going on, and you are involved in patients that are often in the worst time of their life, and especially in A&E because they're straight in, and you're often not far off the first person they see, because as soon as the doctors see them and kind of forming some kind of idea of what's going on, they want to image them and confirm diagnosis. So yeah, there is lots of heavier stuff, but I think it's just the mix, and you never know really what you're going to get is a big pull for me.
Yeah, I bet. And I suppose so. Coming on to sort of stuff that you're on or involved in at the moment, I know you put a post out via Twitter, so around neurodiversity. I think you're working with a couple of people around this, but what is neurodiversity?
It's like a whole social movement, and it's the removal of differences like autism or ADHD or dyslexia, dyspraxia from like the medical model, where their pathologies and their illnesses, and it's more exploring the idea that we're just diverse and people have different, just as people have different colour skin or different heights, or there's a wide diversity of different people, and the same thing goes for their brains. So there's basically it's a social movement that is kind of putting it back into empowering people to think of it more as a difference rather than a difficulty, a disability. Although there are of course difficulties and disabilities involved with being neurodiverse, but they're emphasising also the positives. So for example, someone that's dyslexic might struggle with spelling, but then also might have amazing problem-solving skills, which they wouldn't have if they wasn't dyslexic. So it's not only viewing the world as diverse, but also emphasising the positives, which people often don't think about. And some key terms that are in the movement. There's neurotypical, which is the majority group and what society deems as normal. And there's neurodivergent, which is the minority group, which have brains that function differently. And then there's neurominorities, which a lot of writers and papers use as a term to represent what the medical model would call conditions, so autism and dyslexia, etc. And it's a way of, as well, like being social movement and getting some kind of traction behind it. It's kind of bringing a lot of awareness about different social minorities as well. So there's lots of misconceptions, I think, in the mainstream public and through the media about, for example, like ADHD just being a thing that naughty children get, naughty little boys get, whereas because that was my view. Like a couple of years ago, it was just for naughty little boys, and it's something they grow out of, or they get medicated for it, and then there's a whole media thing about them turning to zombies, medicating kids and all that kind of stuff. And I think this whole movement is bringing more awareness of people, that ADHD is such a wide ranging thing that can affect people of all different genders and races, and also ages. It can be an adult thing as well, and it is in my case.
Yeah, it's very interesting. Lots of different terms there. And I think, to be honest, I hadn't really come across the term neurodiversity before. So just with a bit of research from what I saw, it did start up, or it was first sort of talked about in, I think, 1999 by someone called Judy Singer, who started championing it. And so she described herself as somewhere on the autistic scale, which is something I've heard kind of fly around in a joking manner quite a lot, I think, with friends and stuff like that. And then just another quote that she said, which really stuck with me, that it's not possible to separate the person from the autism. And I think exactly as you said, that's a really good way to look at neurodiversity as kind of a celebration of individuality rather than just something that needs to be fixed.
Yeah, definitely. And I think it's interesting you said about it's somewhere on the scale, and people using that as like a jokey thing, because people use the term autistic as like a slur or a negative thing, whereas you can see on Twitter people use the hashtag actually autistic, which is kind of differentiating themselves from that and saying, I am actually autistic. This is not a kind of a slur or a slang thing to say. So yeah, I think it's kind of exciting the way it's going at the moment, because there's so many awesome communities on Twitter and on Reddit, that support networks, that people never would have had this before. And so not only is the knowledge about it growing, but also the support around it is growing as well.
Ben, obviously I don't know what your experiences have been, but I've got a 10-year-old, he's at school at the moment, and he is interacting with students that are neurodiverse. And it is really important, I think, from that really fundamental age and their level of education, to really support the conversations that people have. I know for a fact that my son's come home and said, "Oh, that naughty child," but I know it's because he's got autism. And there is we really do unpick that at home, and we do go through, well, he isn't naughty then, is he? And it is so important, I think, sometimes the role of educators in schools, especially in primary schools, where you do start to get to that kind of stage where you are essentially fundamentally developing stereotypical views. And I think it is really nice in some respects, because I know from when I went to school, it was just nothing that anyone would necessarily speak about. And it is nice that you are getting younger students who are being diagnosed, and they are openly communicating and talking about it and educating the other students. Do you feel that's something that should be actively encouraged? I'm just thinking not necessarily even within healthcare, but also education.
Yeah, definitely, 100%. I mean, when I was at school, I don't think anyone ever talked about it. I mean, it's in the 90s. It was, my parents never had the conversation about it with any of the teachers. No one expected it in me. No one, and then I didn't even know anything about it. And I think that it's definitely getting better now. But there's still lots of teachers and educators that don't know enough about it. Not just as a way to diagnose it and to spot it, but also know enough about, like you say, the stereotypical stuff. There's teachers that are just assume that it's naughty kids, and it's almost like there's a conspiracy, like don't believe in it. It's quite shocking, but I think that's definitely, as time's going on, it's getting better and better, and it's actually the children that are getting better, not the educators. They're just the generation now of young people that are so much more socially aware, and it's really encouraging that it's getting a lot better than the times that I had at school, where I had one teacher before when I was in year 4. So I can't remember how old you'd be in year 4, but I remember it being year 4, and I would never ever do the work, any writing. We'd sit down and write a poem or whatever it was going to be, and I would end up just walking around the class and not doing any of it. And I remember those times, looking at the end where the bell's going and look at my page and there's nothing on there. So one time he said, right, no one in the class can leave until Ben has done a page. So they got the whole class then, it starts off with them cheering and having a laugh, and then as time's going on and I'm writing, nothing's really coming out and I can't think of anything to write, then they're getting more and more frustrated, and it's turned into a very unpleasant situation. I mean, to teach us to do that then was like a normal thing. It was just like encouraging me to write, kind of thing. Whereas I think now that kind of thing would never happen. So it's definitely improving, but it just needs to improve faster, I think.
Yeah. And I think also as well, just from personal experience, it's having the diagnostic pathways for some children as well. So if parents or educators think that there is potential that children might need support for any kind of learning difficulty, it's about maybe having those resources available to go down that diagnostic pathway. And waiting lists at the moment, I know from Sheffield, at 2 years before you even necessarily get a diagnosis, if there is a diagnosis to be had, before you even then go on to a waiting list potentially for treatment or support or referral. That is a long time when a student potentially could be struggling, especially as part of kind of that fundamental age where they are transitioning to secondary school. It can be really, I would imagine, worrying from parent and also student perspective. So yeah, absolutely. I think there's lots we can do, lots of investment. We always say, don't we, about everything to do with the NHS, unfortunately, it needs investment, doesn't it? But
there's a really shocking paper that was written this year about ADHD, and it's basically got every charity to do with ADHD, all the experts in ADHD, they've all co-authored this paper, and it just outlines exactly what you say, the long waiting lists and the impacts of that on people, and basically all the health impacts people have for being undiagnosed and untreated ADHD, and the difference it can make if you get the right treatment, the right diagnosis, and then the right medication, if that's the route you want to go down. And it's a terrible read to know that that's happening now in 2021. And I tried to get referred to get diagnosed, and not even actually to get a diagnosis, but just to have an appointment to then get referred to maybe get diagnosed. And that was a 6-month wait just for that appointment. So it's shocking, but
So Ben, you've kind of touched on your story a little bit, but are you happy to kind of fill us in on your experience?
Yeah, totally. Yeah. So I've as I said, had trouble in primary school. I was just a kid I was never naughty in a nasty way, but I would never do the work, and I'd always be chatting and walking around the room and doing anything other than what the teacher had asked. And from that age, then from about year 4 onwards, I had private tuition at home because I just wasn't hitting any of the marks for development, and that continued right up to GCSE. I had a private tutor for GCSEs as well, and eventually I managed to get out with mostly C's. just about skin of my teeth kind of thing, and that kind of was left as a oh well, kind of got over it kind of thing. Like no one ever really talked about that, and I talked about it with my parents now, and they kind of think, oh yeah, there might be something there. But yeah, so I did my first degree, did my bachelor's degree, and then as I was embarking on my PhD, I started thinking I must have seen somewhere, maybe on TV or something, about dyslexia, and I looked down my grades and all the creative stuff, all the composition and musical stuff and programming stuff was like high grades firsts and stuff, and then all the writing part of it was all like 2s and lower, and it just kind of clicked that something's not quite right there. So I went to the university, and the difference between the two systems is like, because dyslexia is classed as a learning disability or difference rather than a medical thing. So you can get assessed through universities, and university will fund it. So I got assessed, and I had moderate to severe dyslexia, and it kind of clicked that all my life story up till then, it was life changing to know that a lot of things wasn't my fault, that I wasn't trying hard enough, or I wasn't. It wasn't me not putting the work in. It was to do with just the way that my brain works, and that helped me a lot. Accepting myself was a big thing, and then as I went on, like I say, I had quite a big spell of mental health issues that knocked me out for a year pretty much. And it was during that time, talking to a psychiatrist, that suggested ADHD could be a factor in it, because I'd always had these problems with depression and anxiety, but never could put my finger on the root of it. What was the issue? And so we found. I went to get eventually an ADHD diagnosis, and that was in June this year. So I got diagnosed with dyslexia at 23 and ADHD at 31, and this has been a huge life-changing thing as well, because suddenly all these things in my life kind of click. Every decision I've made has been informed by that, and you learn so much about yourself. And as I say, the self-acceptance has been a huge thing, realising my strengths, my weaknesses, and being okay with the fact that some things I can't do as well as others, and that's just me, and that's okay, and not to beat yourself up about it or get anxious about it. And other things I can do better than some other people, perhaps, and just accept yourself. And it's been life-changing, yeah.
Thank you for sharing your experience, Ben. I mean, it sounds quite challenging, and I suppose being an adult and figuring this out, as you said, that kind of, it all clicks and you understand all of your movements and your thoughts and your decisions. It's quite a lot to go through.
Yes, it has been but I think it's a common story, people getting diagnosed later in life, and there's whole groups on social media that just talk about that sort of thing, because it's kind of bittersweet, because you look back and everything about your life makes sense, and you can understand it, and you, like I say, you can accept yourself and kind of give yourself a break. But then also it's bitter, because you're looking back and thinking, if I knew earlier, what would I have done differently, and what would have changed. But I mean, you can't think like that, because otherwise you'd never leave the house, would you?
No. And it's interesting what you said. So just did a bit of research. There was a paper that came out in 2009, just off the back of a study. I think it was 27 people who took part. So I think it's called the Brain HE project. So I've had to write this down because it was quite a lot to try and remember. But best resources for attainment and interventions re neurodiversity in higher education. So it was a mix of students, so with different learning differences, and exactly as you said, whether they were diagnosed later in life or some of them had found out some of these things early, that actually, understanding their strengths and weaknesses as individuals, but they all had exactly the same difficult schooling careers. So, as you kind of alluded to, so people bullying or teachers kind of singling them out because they couldn't quite understand what was going on. But interestingly, I think it was 41% had higher self-esteem and confidence in their abilities after that. And I think 73% of them had considerable career ambitions with sort of clearer goals compared to someone who wasn't in that cohort, which I thought was really interesting. As I said, it probably resonates with you. So similar to that, and I think, well, you're a doctor now, so
Yeah,
but
definitely. That's my story, and yeah, it really that study kind of highlights that. Yeah.
there's a person I used to work with before who had a learning difference in a different job, and they'd kind of mentioned about sort of understanding their challenges, where you don't always get praise externally. So similar to people not understanding, where you mentioned that they may not be good at spelling, but they understand the other side, so they might have a better spatial awareness, for example, in DT or something like that, design and technology. But yeah, it's about the inner applause, and that's something that really stuck with me that they went through with their experience. That you've done something well, you're not necessarily going to get the applause or validation from outside, but you have to get that inner fist bump, is what was what they would say. So like many things in life, it's kind of, as you said, just about self-realization.
Yeah, definitely. Yeah, and yeah, I think just knowing that it's not your fault was like groundbreaking for me. But yeah, you definitely have to build that. Yeah, that's a really good way of saying it. Yeah, like inner applause, because sometimes once you know yourself and you know what you're good at and what you're not good at, other people don't know it externally, so they don't know the challenge that you're doing. You're facing just to do something that they might think is easy and simple. So yeah, definitely. You're your own crowd, aren't you? So.
Ben, do you think it's made you more resilient?
Yeah, definitely. I think I approach things differently now. Yeah, I think I approach things with a confidence that I never had before, because I'm more like I'm me, and I'm proud to be me.
Yeah.
And I think then if I do face any kind of adversity or anything like that, it's easier to accept, because I am what I am. I can only do what I can do, and that's the way it is. Like, so there's no kind of like, oh, I should have done this better, or I should have done that better, because I just know this is what I can do.
Oh, brilliant. So Ben, obviously being a lecturer, my next question is very much from a selfish perspective. What do we need to do better? So I already know that we have students and have had students in the past that maybe haven't been as well supported, or haven't necessarily wanted to disclose maybe some of the learning difficulties, or the fact that they are or would class themselves as neurodivergent. So what is it that we need to do from an higher education institute perspective, but also from a clinical perspective? Because I also fully aware that even if you can have adaptations within academia, they aren't always translated to their clinical environment. So what is it from your experience that we need to do better, or maybe change or improve?
Yeah, it's a really good question, and so I got into the 150 leaders program, and then in that part of that leadership program you do a project, and I wanted to do some research on this exact topic of how well do students that have adjustments in academic stuff, how does that work when they go on to placement. So for me personally, it's been I've just gone through the system of that. So I've just had a meeting with my placement tutor and my personal tutor, and we've discussed the adjustments and how practical they are. So I had the assessment with the university, and they come up with all these things like I need extra time, and I need not to sit by the window, and all these kind of abstract things that would definitely help. But how do they work in A&E? Extra time, right? Like I'm supposed to wander off in the middle of an exam and go and think about things. It's not very practical. So I think it's a hard question to answer, because there's really no research in the area at the moment. So we haven't really got like a foundation to build ideas from at the moment. So we don't really know. What I'd like to do is do a study where you look at the experiences of neurodiverse students on placement, and then see what they need, and then test out the adjustments. So I've just gone through it, and I haven't actually been on placement long enough to give it a proper try. But there's some really simple things that you can do if people do have adjustments, and that's things like thinking about when you're going to question them. So it's natural that you got your student, and you want to know, test their knowledge, make sure they know why they're doing an exam, what exams did it for. But there's a time to do that where you get situations where there's a patient there and they're about to X-ray the leg and they're positioning the leg, and then the radiographer's coming over and saying, "What are you doing that for? Which way is that going to go?" Asking these questions, which are very important questions, but I find that I can't cope on doing all the different things at once. So I either cut the patient out and answer the question, or I cut them out and look after the patient. So little things like that, which people wouldn't perhaps think about because they're tiny things, but they would affect someone's self-esteem over time, I think. But I think there just needs to be a lot more research in this area, and there needs to be work in forming an environment where people are able to disclose, because the research that is available, that's in other healthcare professions, there's lots of the problems people have is they haven't disclosed, so they can't then have adjustments. So no one knows there's a problem, so they can't then fix it. So I think there needs to be a lot of work in making it an easy place to talk about these kind of things, because there might be a stigma. I mean, I don't feel that there's a stigma personally, but I'm very open. I live my life like an open book, really, where a lot of people are a bit more conservative. Are they going to walk into placement on the first day and tell them that they're dyslexic or they've got ADHD or whatever, and then ask them to then adjust things for them? It takes quite a brave student to do that, and it is all the pressure is on the student to do that work. So the adjustments you get at university don't automatically, they don't get a letter on placement about the student. You're the person that has to go and tell them, and to organise the meetings and to make sure the adjustments are there. So you have to be your own advocate, which for somebody that's shy on their first placement in their first year, it's going to be a difficult thing to do, isn't it? So there may be some work there as well.
I was going to say, from a HEI perspective, just being a student's representative, do you think that would help in terms of being with a student when they maybe disclose that? And I know with COVID and going digital, there is technically no reason now why you couldn't be accessible from a lecturer perspective and have a student present with a clinical supervisor or a practice educator to have those conversations. Do you think that is something that could help? Yeah.
I think just having that support around them would be really useful. And also perhaps having another student, not necessarily a neurodiverse one, but someone that's been in that placement, knows the staff. So you've got kind of like it's not a black or white situation. There's more more grey area, more support.
Yeah, absolutely. I definitely think more research is needed, and that's maybe where you come in. You're yet to do your third year dissertation, haven't you? So there you go. There's your project about to be started, and then obviously PhD. They'll be all over you, Ben, to get you to go through that educational pathway. But absolutely, and I know it's something that Janice St John Matthews highlighted as part of her podcast in terms of the support that people need, but not in a supportive, derogatory way. It is just the fact that actually disclosing any characteristic or any support that anyone needs within the health service shouldn't be a negative experience. If I had mental health issues, why should I feel worried about having to disclose that to colleagues? It's all of that packaged, isn't it, in terms of maybe how we're perceived, but also having the confidence to be able to know that anyone that you talk to within that healthcare setting is going to be supportive, irrespective of what it is that you say. And I'm sure there's deeper societal things that we need to unpick as to why maybe some of those views and stereotypes exist, but I think just having the conversations is really important.
There's a disability report by the British Medical Association came out a couple of months ago, and they found that people that had disclosed, 77% said that they felt that the staff would treat them differently now, negatively. So I think there's definitely having these conversations, because I think a lot of it is probably the perception people have of what people are going to think rather than what actually people think. I mean, we're in healthcare or we're in education, and the reason we do that is because we caring people that want to help people, or want to support people, or want to teach people. So you're surrounded by people that are kind, caring people, yet there's still this fear of telling them even. So there's definitely, it's a lot of internal things going on, and like I say, it's a societal thing that it's probably going to take a long time to unpick and understand.
It's I know on Twitter as well, Ben, you're very open and honest about this, and I did see that you've made like a visual reference book, which looked pretty cool, to be honest. Can you tell us a bit more about that?
Yeah, I'm glad that you've noticed my open honesty. I was actually inspired by Janice St John, who just referenced, because she had it on her Twitter bio, like dyslexic, and just reading that, I was like, oh, okay, so it kind of normalises it, doesn't it? It's the more people talk about it, the more it's out there, the more normalised it gets. Yeah, so that was inspiring. That's why I kind of put it on my bio, and I try and speak about it as much as possible. But the reference book was one of my adjustments actually. I was saying that often in a busy department, we're saying in A&E X-ray, for example. And then we have a patient come in that's a lumbar spine, and I've got like a couple of minutes and I can quickly look for the book and remind myself of lumbar spine. And then as soon as I've done that, there's another patient coming through the door and it's a toe. I know how to do those. I've revised it. I've done the exam. It's in there somewhere. It's just I have trouble recording that information quickly. And I find that the books that we use, Clark's and etc., they're very good, but it's a lot of reading to quickly access that information. Whereas I'm dyslexic, ADHD, visual stuff works the best for me. And people that aren't neurodiverse, people that are neurotypical might find that visual stuff works for them as well. So I wanted just to do a diagram for each position, so I could just quickly turn to it, see it, go and do it. And that was my what I wanted to do as one of my adjustments. That was suggested to me by my practice educator and personal tutor. And my practice educator, who I think is neurotypical, she showed me some of her notes from when she studied 20 years ago, and she had little diagrams. And I just was like, okay, yeah, so this could be something that I keep and in 20 years' time look back on. And then just being active on Twitter, I thought, well, I might as well share these and see if anyone's, if they're useful for anyone else. And I've been really surprised by the amount of people that have commented saying that they're useful, because that's the thing with neurodiversity and these little changes and these things you can do to make it more inclusive don't just benefit the people that are neurodivergent, but benefit everyone. So that's what I've learned from that exercise.
I was going to say, Ben, we have loads of students with lots of different learning styles, and sometimes as an academic, because we fundamentally have lots of education to support us in being able to educate people with different learning styles, but that education doesn't always exist within the clinical workforce. So it's really hard. We as academics are going, right, you need to support these learners by ensuring they have time to be reflective, and they're like, a reflective, what are you talking about, Joe? We've got lots of patients. I don't understand how we're supposed to kind of adapt to educate and find out about what learning style everyone has. So, and that's obviously where the role of the practice educator is really important in taking on that additional responsibility. But it is really interesting just how many students have already said to me, oh, Ben's doing some amazing things, and yeah, we should get him to produce some things for us in radiotherapy. So you never know, you might have therapeutic radiography students asking you to produce some booklets for them as well. But I always know I had a book, and I'm sure all therapeutic radiographers would have, as they were students, in their pocket, tucked away for years and years and years, with every little bit of knowledge that they know that they don't use every day, but they will need to call upon. Dose calcs were always my thing. I was like, oh, let's just pull up my dose calcs back in the day of hand planning and things like that. Absolutely. So yeah, Ben, I think you could probably earn a living from producing some of these.
If not, you could definitely do another PhD around it, couldn't you?
No, I know. There's so many research pathways you could go down in this, because it's such a huge thing, isn't it, that's not really been studied before. I mean, you could do a whole PhD just on autism, autistic radiographers, So yeah, there's so much research to be done, and that's why I'm really happy to be talking about it, as many places as I can. Not only just to raise awareness, but also to try and inspire people to take up research in this area, because there's a lot of people that have potential to be having a hard time not having the adjustments. So if we all get stuck in, we can fix it.
And I suppose a very quick caveat would be that we talk about personalised care for patients. Maybe it is now time for personalised sort of looking at, exactly as Joe said, to educating, but also when people start working as newly qualified, what is their learning style when they're on the job, because it can be quite new if you're not in the same department that you trained in. Just learning to tell to patients where the toilets are, for example, is a certain way I always had to remember, because I know I just couldn't find them. So, but I suppose it coming on quite nicely to Ben, that I know you've just got some of the support ideas and stuff, but do you have some top tips for sort of patients, students, healthcare professionals that are listening?
Just a couple of things jumped out at me. But I think firstly is have a think about your own style and your own way that you learn, because there's so much of this of neurodiversity is undiagnosed, and a lot of that I think is by people not knowing what to look for, because especially for me, you are how you are, and that's how you've always been, and you don't really consider how that would appear somewhere else. So you just think that this is normal for you, but is it normal for everyone else? And if you're working 10 times harder than everyone else to do the same things, then it might be worth looking into your own approach, your own learning. So that would be a tip, is to think about your own thing, but also then for radiographers and healthcare professionals and educators is to think, a bit of a challenge, like think about how you support your staff and students that are neurodivergent. Is it something you think about? Is it something that you are keen on progressing, or is it something that you've never thought about till now? And what can you do to make sure that you're neurodivergent inclusive?
Oh, perfect, Ben. Some really good advice there, and I really do hope that people take that on board. I absolutely know this is not the last we see or hear of you, Ben, at all. I know that there are great things to come of your future, and we're really glad that you're part of the radiography profession, and hopefully take this forward and do lots of research. So, thank you all for listening to Rad Chat. Your hosts today have been me, Joe McNamara, and my co-host, Naaman Jolka Anderson. If you're utilising this podcast for CPD purposes, consider the reflective questions posted, along with links to the resources and also literature discussed within the podcast. To receive your accredited CPD digital badge, please complete the Google form linked with the podcast. Our next guest to feature will be Dr. Richard Simcock, who is on the Chief Medical Officer's team at Macmillan. So thank you ever so much for listening. Take care and good night.
Thank you.